Well, good afternoon and welcome to our Facebook Live here at OrthoVirginia. My name is Dr. Ted Lambert, and I'll be talking to you today about total hip replacement in 2025. What's the latest? I'd like to take a minute to talk about OrthoVirginia, which is our company. We are the largest musculoskeletal provider of care in the Commonwealth of Virginia. And as you see on the map here, we've got pretty much the entire Commonwealth covered. We are divided into 4 regions with over 150 doctors throughout the state of Virginia and 35 separate locations. I'm here in Virginia Beach today, and you'll see, there it is. There's our office in Virginia Beach. It's located right across the street from Virginia Beach General Hospital, and that's where I am now, talking to you from our office. And you see the website and the phone number if you have any questions or want an appointment. So a little bit about me. I am an orthopedic surgeon. I specialize in hip and knee replacement. Pretty much all I do at this point. Been doing it for about 20 years. I'm going to give you a little background about myself. I grew up in Maryland, just across the Chesapeake Bay in a town called Salisbury, about 3 hours north of where I am here in Virginia Beach. I did go to the U.S. Naval Academy in Annapolis. I graduated there with class in 1992. And I was very fortunate to be selected to go to medical school where I went in Philadelphia. And following that, I got my orthopedic training, what we call a residency, at the Naval Medical Center, Portsmouth, here in Virginia, about 20 miles west of where I am now. After that training, I got another year of specialty training, and this is really where I learned to do hip replacement and knee replacement at the Hospital for Special Surgery in New York City. This is annually known as one of the best orthopedic hospitals in the world. After that, then I started my practice in the military, Portsmouth, Virginia, taking care of active duty sailors and Marines and retirees, mostly doing hip and knee replacement. And during my 20 years in the Navy, I spent time overseas in Iraq and Guantanamo Bay, Cuba, and was on a ship for a couple of years. And then eventually I retired from the Navy and I joined OrthoVirginia here in Virginia Beach in 2016, and that's where I am today. Now we're going to talk a little bit about what you came to listen about, and that is hip replacement. So I'm going to talk to you about the details of the surgery for most of the talk, but I want to take a step back and talk about who actually gets a hip replacement and who needs to have this done. So the primary reason people get a hip replacement is for osteoarthritis of the hip, far and away the most common reason. Some other things that can cause a patient to need a hip replacement are inflammatory arthritis, such as rheumatoid arthritis, or psoriatic arthritis, and then some other less common conditions. One is called osteonecrosis, in which the femoral head, the bone of the ball and socket joint, actually dies from lack of blood supply, and that causes the hip to degrade and need a hip replacement. And then some other reasons are a fracture. Elderly hip fractures are one reason to get a hip replacement. And then childhood hip disease can cause some sequelae that can wear the hip out, such as developmental dysplasia of the hip or Perthes disease. Most of my patients that I see for hip problems do not end up getting surgery. As a matter of fact, they get non-operative treatment, and that consists of primarily weight loss, which is a big help in reducing the forces across the hip joint. We send patients to physical therapy to strengthen the muscles around the hip, and then I give prescriptions for non-steroidal anti-inflammatory medications. Simple ones like ibuprofen and naproxen can help, as well as some injections with a cortisone or steroid into the hip joint can give temporary relief. And when we try all these things for patients with hip problems and they're still having persistent pain and it's interfering with their activities of daily living, that's when we consider a total hip replacement. And that's what I'm going to talk about mostly today. So, total hip replacement in 2025. This is a brief overview of my talk today. I'm going to talk a little bit about the history. We'll get into the material of the implants that are placed in the hip during a hip replacement. I'm going to talk about the different surgical approaches to a hip replacement, including the anterior approach, which is the one I currently use. We'll talk about the type of scars that can be used for this procedure. And we're going to talk about pain after surgery and try to alleviate some fears for patients considering this. And then I'm going to talk a little bit about what I perform in the operating room and the technology I use to get the leg lengths correct in hip replacement, because we do actually change the length of the leg when we do a hip replacement. And finally, I'm going to talk about same-day surgery, which is a new trend in orthopedics. So before we talk about today, it's important to remember the history of where total hip replacement started. It started with this man, Dr. John Charnley, in the late 1950s and early 1960s. He actually is considered the father of the modern hip replacement. He designed these implants and helped manufacture them himself. In addition, he was the first one to use bone cement, which helped fix the implants to the bone so they didn't move. He discovered some early complications such as infection and came up with some ways to prevent this that are still used today. So we have him to thank for a lot of the advances that have resulted in where we are today. And where that is here in the United States, over 450,000 total hip replacements are performed every year. It's become quite common. So one of the big advances in hip replacement in the past 15 years has been the anterior approach. When we talk about approaches to do a hip replacement, this is basically how a surgeon would get from the skin into the joint to replace the joint. There are many different types of approaches. The more traditional approach is the posterior approach done from the back. I did several hundred of these in the first probably 10 years of my practice, and they do work quite well, but they cut muscles and they do have problems with dislocations. So the anterior approach, which I currently am using now, doesn't cut any muscles at all. The picture that you see on the slide shows these metal retractors used during surgery that pull the muscles away from the area where we're working to get to the hip joint. This allows me to perform the surgery through a smaller incision and gives patients a quicker recovery. In addition, the patients don't have any hip precautions when the anterior approach is utilized. What that means is after surgery using the old way, there were certain positions patients weren't allowed to move in. You had to sleep on your back with a pillow between your legs for 6 weeks. You couldn't cross your legs. You couldn't bend down to pick up something off the floor because there was a fear that the hip would dislocate or pop out of socket. Using the anterior hip replacement, these precautions are no longer needed because the hip is much more stable. And this because of less tissues are cut. In addition, during the surgery with the anterior approach, we use X-ray imaging while the patient's asleep on the operating room table. That allows me to put the parts in exactly the right place. With the other approaches, we don't use imaging. You have to use feel and some local landmarks, and it's not as accurate as it is with imaging. So these are all reasons the anterior approach has become so popular today, and I've been performing it since about 2012. What are the implants made of? I have some examples here that I'm going to show you. A basic total hip replacement is made up of 4 parts. The first part is the acetabular component. This is the part that goes into the socket of the pelvis. And the back of this implant is made of a porous surface. The implant is made of titanium, and this porous surface is rough. And I put it into the bone, and it sticks into the bone, and the bone actually grows into this implant over time. Once the bone grows into it, basically the patient has it to keep for life. So this is the first part made out of titanium. Inside of that one, we snap the liner. This is made out of polyethylene or plastic, ultra-high molecular weight polyethylene. In about 2000, these parts changed dramatically, and the company started radiating them in the factory to cross-link them. Cross-linking caused this plastic to have much better wear properties. This has always been the weak link in total hip replacement, the plastic, because it would wear out. With today's technology, these plastic in the laboratory is lasting 50 to 75 years, which is much longer than the 20 years we used to get out of the plastic. On the other side of the hip, we have another titanium piece, which is called the femoral stem. And this is made out of porous coated titanium, and it's in a tapered shape. So it wedges into the femur and it has a little collar on it. And this part's called a trunnion. This goes down into the femur bone. And on top of that, we have a ceramic ball. So the new bearing surface is ceramic on plastic like this, and that's the new hip joint. As I discussed, there are multiple ways to get into the hip. The approaches are different. This is a traditional scar from either a lateral or a posterior approach. It's rather large. It's located on the side, a little bit towards the back of the hip. It works fine. It does leave a little bit of an unsightly scar, done to a scar in the front. Most anterior approaches are done with a vertical incision in line with the leg or the femur. This particular incision is called the bikini incision. The bikini incision for anterior approach heals a little better cosmetically because the scar is put in the line of the creases of the skin. So the skin heals much more naturally this way. It doesn't drain as much and it's a little more cosmetic appearing. I've been doing anterior approach through this bikini incision for about 2.5 years and I've had some pretty good results with it. One of the things that patients are very concerned about when they're considering a hip replacement is the pain after surgery. So hip replacement is a big surgery and no surgery is painless, but we're getting a lot better at controlling patients' pain. So how do we do that? Before the surgery, the patient is given medications to help with the pain, simple anti-inflammatory medications, Tylenol. In addition to that, they get an anesthetic for the surgery. Most of my patients, they get what's called a spinal anesthetic, which numbs you from the waist down, and then you get medicine in the vein called propofol, similar to what patients get for a colonoscopy. So you're completely knocked out for the surgery, but you wake up very quickly, which is helpful to incorporate physical therapy soon after the surgery. During the surgery, I inject a lot of medicine in the hip, numbing medicine and anti-inflammatory medicine that stays in the body for several hours after surgery to help with the pain. And then after surgery, of course, we get pain medicines, both Tylenol and an anti-inflammatory, in addition to some narcotics. Now, most of my patients after a hip replacement take narcotics for the first 1 week, maybe 2, and that is it. Most of my patients use 10 pills or less of narcotics for pain control after the surgery. There are some easy things that we do to help with pain after surgery that do not have the side effects of narcotics. Narcotics are not great because they do have a lot of side effects. But simple things like icing the hip, and resting. So when you finish the surgery with all the numbing medicine in there, some people feel really good and they want to go walk a lot. I recommend they do not do this. And I have a very specific protocol after surgery that limits the step count for each individual patient per day to help control the swelling and therefore control their pain afterwards. So with all of these modalities, the surgery of hip replacement has become a lot less painful than it has been in the past. Now here's an example, a pelvic x-ray. When we take an x-ray of the pelvis, the images are placed as if the patient is facing us and looking at us. So if you see on this image, the metal marker in the middle is a magnification marker. And this is what I use for my patients when I'm trying to fit the sizes for a total hip implant. The left hip is the normal hip here, and I'm going to try to get the arrow to demonstrate the cartilage remaining between the ball and the socket. That's normal space there, sort of like the treads on the tire. This is a so-called normal left hip. Now, if we move over to the right hip, you'll see the space is completely gone here. And as the space goes away and you stand up, the whole leg moves proximally a few millimeters. That causes the leg with arthritis to be shorter than the other leg. So during hip arthritis, the affected side is usually shorter than the other side. So when we do the surgery, we have to take that into account in order to get the leg lengths equal when we're all done. So there are many ways that we do that, and I'm going to demonstrate. This is a templating view of the hip. So this is the same x-ray, and I'm using this as an example of some software that's being used to fit the correct sizes. And you'll see in the middle of the screen down at the bottom that the right leg is shorter than the left. So the leg getting surgery, the right leg is shorter. So in the templating software, I use this information to lengthen this right leg by 5 millimeters. And during the surgery, I'm actually going to measure it to the millimeter to make sure we get that exactly right. And then it also helps me decide how to put the parts in. And this is sort of the preoperative plan that we have going into the surgery. And then I take this into the surgery, and this is a picture of some of the software that is used during the surgery. So the patient's actually on the operating room table. We take this image with something called a fluoroscope, similar to an x-ray machine. And then the software helps us determine what their leg length was before the surgery when we take an x-ray, and what it is now with these provisional or temporary parts in place in the middle of the surgery. So you can see that it tells me to the millimeter how much longer I'm making the leg, how much offset, which is a measure of how far the femur is away from the pelvis. And all the mechanics of this are very important because the muscles around the hip need to be the appropriate length so they're good and strong. So this is the intraoperative software that you can use with an anterior hip replacement using imaging. the goal of all this is to get an x-ray that looks like this. And this is the final x-ray that patient with a completed total hip replacement with a titanium socket and the titanium femoral stem and a ceramic ball and a plastic liner. But most importantly, the leg lengths have been restored to what they were before they got arthritis, and the mechanics of the hip are sound, so this patient should recover relatively quickly. So the last topic that I want to talk about is where total hip replacements are being performed here in 2025. So when I first started and practiced in the early 2000s, all of the hip replacements I did were done in a hospital, traditional hospital, which has inpatient beds. Patients stay overnight. They have an ICU, they have an emergency room, they have a lot of things, a lot of great resources. And today, in 2025, half of my hip replacements are now performed at an ambulatory surgery center. What an ambulatory surgery center is a place with the same operating room equipment, the preoperative area, the same recovery room, the same personnel, nurses, anesthesiologists, but no overnight stay capability. So the patients have to go home the same day, and I'm going to walk through the differences between these two. So an ambulatory surgery center, like I said, state-of-the-art facilities, they have great operating room things, but you don't stay overnight. So what are the advantages of not staying overnight in a hospital? If anyone's ever been in a hospital, you know that it's very difficult to sleep in a hospital, and sleep is very important for your recovery. There's a lot of bells and whistles going off, a lot of people, a lot of action, a lot of noise. And if sleeping in a familiar environment, even the same day as your surgery, is very important for your recovery, and that's one of the advantages of having surgery at an ambulatory surgery center. Hospitals have sick patients in them, and some of them have infections. These infections can be contagious, and staying away from them is the best way to go. If you happen to be a sick patient and you yourself have an infection, then a hospital is the right place for you. But if you're a healthy person that has hip arthritis and you simply want to get a hip replacement, risk of infection is a little lower at an ambulatory surgery center. In addition, patients in a hospital, kind of a complex thing to get a pain medicine. You've had surgery, yes, you're going to have some pain. If you're in a hospital, you ring a bell. Eventually, someone comes and answers you and asks what you need, and you tell them you need some pain medicine. They check your wrist bracelet to confirm the right name. They go to a locked space where they keep the pain medicine. They look up your name. They make sure you don't have any allergies. They pull out some pills, and then they get it back to the room and they get it to you. That takes some time, and there's room for error. When you're at home and you have pain, you reach the bottle of pills on your bedside table and you take one. It's as simple as that. So that type of thing is a little easier for people who are capable and able-bodied. And then as cost becomes so much more prevalent in medicine, it's a little cheaper for the patient to get their surgery at the ambulatory surgery center than it is at a main hospital. Not the prime concern, but just one thing to think about. Candidates for same-day surgery are patients that don't have severe medical problems, like had a heart attack or significant heart disease. Maybe they have sleep apnea. These patients are better served in the main hospital. Again, where 50% of my patients go. So main hospital is still a place for surgery there, absolutely. Patients that are going to go for same-day surgery should be mobile. What I mean is they should have one bad hip, not two bad shoulders, two bad knees, a bad ankle, and be in a wheelchair, because it's hard to mobilize you to go home the same day in a few hours at an ambulatory surgery center. And then the last and probably most important is a supportive coach. And this can be your spouse, it could be a family member, somebody that's going to be able to take you to and from the surgery and maybe stay with you for a few days to make sure you're able to get around and get to the bathroom and things like that, just to check up on you. As I said before, about half of my patients go home the same day for hip replacement here in 2025. The hospital is still a good place to have surgery for the right patient. Patients who have a lot of comorbidities, maybe they're a little older, they don't have help at home. It can be very helpful. There's a lot of experience at hospitals from both the anesthesia team with lots of anesthesiologists. They have an ICU and cardiology team. This can be all very helpful for the appropriate patient. So when I see a patient that needs a hip replacement, I try to tailor it to the patient of where they want to go and where's the best setting for them to have this type of surgery. That concludes the formal slides I had. I think we're going to go to some questions now from the audience if we have any of those.
Thank you so much, Dr. Lambert. Yes, we are going to be answering questions. We will answer questions submitted earlier and questions submitted live. So if you are watching this live on Facebook, please feel free to leave questions in the comments. We will answer as many questions as we have time for, but we won't necessarily have time to answer all of the questions. Our first question is, when can patients drive after surgery?
So the answer to this question has changed a lot during my practice. When I started, it used to be 6 weeks for all patients, and that was it. Now we have 2 criteria of when a patient can drive after surgery. Number 1, they have to be off all the narcotics, and that's almost always within 2 weeks. And then number 2, they have to feel safe going from the gas pedal to the brake pedal. And that's based on their judgment. So for my patients, I generally say 2 weeks if this is a left hip replacement, because your right foot is generally your brake foot. And then sometimes it takes a little longer for patients who are having surgery on the right hip. But 2 weeks is the earliest, 6 weeks is probably the latest, and it's very patient dependent.
Thank you. Will the replaced hip get as strong as the non-replaced hip?
So that can depend on many factors, but once the joint is replaced and the problem is removed, the muscles around the hip aren't cut or damaged, and they can restore function to what the other side is. So yes, that is the goal, to get the replaced hip as strong as the other hip, but it takes a while, and that's starting to get stronger. It doesn't start until after the surgery, so it can take up to a year. But yes, the target is to get the replaced hip as strong as the contralateral side.
Thank you. Are there weight restrictions for hip replacement surgery?
Body weight, I assume what you're talking about. Yes, there are. For my practice, I try to encourage my patients to lose weight prior to surgery. We have learned that the infection rate goes up significantly over a certain body mass index. So currently that number is about 40, a body mass index above 40, the patients would be strongly encouraged to lose weight prior to having the surgery. There are some exceptions, and that's a general guideline.
Thank you. How long does the surgery itself take?
I would say on the short end, 45 minutes, on the long end, an hour and a half, depending on the patient's anatomy and how big they are and some other technical factors. But it's pretty quick, certainly less than 2 hours.
How long does physical therapy take after surgery?
Again, this is highly dependent on the patient and how they were walking before. I have patients that do no physical therapy. They just do it on their own. And I have patients who are in physical therapy for 6 weeks. So I'd say the long end is about 6 weeks, and the short end is maybe 2 to 4. The hip replacements certainly need less physical therapy than knee replacements. And the therapy is not nearly as challenging for a hip as it is for a knee. So physical therapy, although it is important, is not as important for hip replacements.
Thank you. Do you use the Mako for hip replacement?
I have done several hundred Mako hip replacements in the past. Currently, I am not doing Mako hip replacements. There are some advantages and disadvantages of doing that. It is a good system, but it does require a CT scan ahead of time, which is a bit of radiation, and I feel like I can get as good a result with the current system I'm using.
Thank you. How soon after surgery can you go skiing?
So this is a good question. I assume that the patient will be a good skier and they know how to ski. First of all, I would say it's probably going to be 3 months at minimum. Most of my skiers, and I've had a lot of patients who are skiers, have their surgery either in the spring or summer and then hope to get completely back to full strength by the time the ski season starts. So most people usually wait 6 months. I would say 3 months would be about the earliest I would want a person to try that.
Thank you. What are non-surgical options to help an arthritic hip?
This is a great question. So there are certainly things that can be done short of surgery. Surgeons like myself love to talk about surgery, but there are some basic fundamentals. Number one, by far, is weight loss. So getting your body mass index into a reasonable level is the best way to relieve pain without any surgery in an arthritic hip. Number two would be anti-inflammatory medications. If you're able to take those medically, these are ibuprofen, naproxen type of medications. And then the other options are physical therapy to strengthen the muscles around the hip, which can help some. And then finally, there are some injections that can be offered around the hip, particularly corticosteroid injections, which give temporary relief. Certainly don't cure the problem, but can help with the pain.
Thank you. can someone run if they've had an anterior approach hip replacement?
Absolutely. Someone can run no matter what approach they've had on a hip replacement. I don't let my patients run for distance, as in over a mile, until 6 months after the surgery to let the parts grow in. But I have multiple patients that I have done hip replacements on and have done marathons. Yes, you will wear your hip out sooner if you run marathons than if you don't. However, I'm a runner myself, and I believe that getting back to things you like to do is important. So I think it is okay for patients to run after a hip replacement.
Thank you. If a cortisone shot wears off quickly, is a replacement the next step in treatment?
If you get a cortisone shot for arthritis and it wears off very quickly, certainly total hip replacement is a consideration. It would depend on many factors, depending on the particular patient's situation. You can try another injection or another substance to inject, but usually injections are kind of the last stop before surgery.
Thank you. How long does the replacement last?
So hip replacements, traditionally, we told patients 15 to 20 years. And like I said before in my talk, that the plastic part, this part was the weak point because it would wear out and it would wear about a millimeter a year. Well, that has changed dramatically in the year 2000 when the plastic changed. So the actual plastic will not wear out in a lab for 50 to 75 years, which is dramatically different. So how long will the current implants last? It's really unclear. The current implants that we're using have only been out for about 20 to 25 years. And so far they're doing great. But I think in the right situation with the right patient, depending on how heavy they are, how active they are, they can get way more than 20 years out of a hip replacement.
Thank you. Is hip replacement a treatment for bursitis?
So this is a great question. Bursitis of the hip is not arthritis, and it is a problem that is outside of the hip joint. So doing a hip replacement for bursitis of the hip is a bad idea. Bursitis of the hip is treated with physical therapy and maybe an injection. No surgery involved in the treatment of that particular condition. Arthritis or conditions of the hip joint are treated with a hip replacement. Sometimes people have both. They have arthritis and bursitis. And in general, the hip replacement addresses the arthritis component, not the bursitis component.
Thank you. How long do you wait between hip replacements if you need it in both of your hips?
So patients who have bilateral hip arthritis, I usually have them wait 3 months between surgeries. I have done bilateral simultaneous total hip replacements, meaning both hips have replacement at the same time, in very selective patients who are very healthy and have a strong desire to do them both at the same time. But for the most part, it's a 3-month wait between each hip.
Thank you so much, Dr. Lambert. That is all the time we have for questions for today. Would you like to close?
Yes, I want to thank everyone for taking time to listen to my talk about total hip replacement in 2025. And I just would encourage all patients that have problems with their hip to follow up with their primary care doctor or their local orthopedic surgeon.